Thank you, Professor Scaparotta, for this exquisite presentation on elastography. And I'll now call on the next speaker, on the tomosynthesis. And the next speaker is Professor Maha Hilal, who is from the NCI. And Professor Maha is one of the pioneers in working with the contrast-enhanced mammography. And she has shared in many of the conferences and now will show us her experience in the spectral contrast enhanced mammography.
Thank you, Dr. Asha, for your introduction, and thank you for all the chairmen and my colleagues. My presentation today is about contrast-enhanced spectral digital mammography. The accuracy of mammography is limited in dense presence. Even when tumors are detected, the full extent of the disease may not be clearly depicted. The gross and metastatic potential of tumors can be directly linked to angiogenesis. The tumor angiogenesis factors stimulate formation of abnormal vessels that leak and shunt blood. Therefore, imaging methods with contrast media potentially can aid in the detection and diagnosis of cancer. So, contrast-enhanced spectral mammography is a recent development of digital mammography using the intravenous injection of an iodinated or non-ionic contrast agents in conjunction with spectral mammographic imaging. All our cases were carried out at the National Cancer Institute, Cairo University, using the latest GE digital mammographic system scenographic extension. The examination consists of an intravenous injection of contrast agent, similar to what is used in CT, followed by 2 minutes wait before a mammographic examination was carried out in exactly the same position as a standard screening examination. How does it work? Spectral imaging uses multiple X-ray exposures to reduce the background signal. By suppression of the signal from the normal tissues, the spectral imaging effectively highlights the iodine absorption in the tissues affected by angiogenesis. In our studies, we compared the individual performance of both standard and contrast-enhanced mammogram assessed in the same group of cases. In contrast mammography, we correlated the extension of contrast enhancement with abnormalities seen on the conventional mammography. In one of our study, a big study of about 250 patients, multicentric and multifocal carcinomas were detected in 37% of proved malignant cases, while only unifocal carcinoma was reported on the conventional mammogram. Of course, this will alter the cancer stage and the management planning. Limitations of this technique include the necessity of compression, which, if not adjusted, it could block the blood flow and limit enhancement. Also, it cannot be used for screening because of the need for contrast media, the adverse consequences of the contrast media, and for mass screening it would be considered high cost. Also, the increased time of examination, it takes about 7 to 10 minutes with reporting. Also, it does not provide dynamic information as MRI, since it is not based on temporal subtraction. While it has many advantages, as it improved all the accuracy measures of conventional mammography, reduced the time from detection to the diagnosis. It provides new diagnostic strategies for inconclusive mammogram and for staging. The information you get from the examination are in context with the examination, with the information you know, so it is easily correlated with the mammographic view. It's easy for the technologist and the patient, and is well accepted by the patient, and also the lower cost than MRI. Our first case is left breast upper outer quadrant BIRADS 3 mass After contrast examination, this mass did not enhance at all except for a very thin and regular rim enhancement denoting benign lesion and likely cyst, and this was proved to be a simple cyst by ultrasound. Patient complaining of right pain and tenderness, the retroareolar region of the right breast is the seat of an irregular shape, ill-defined area of symmetrical density. After contrast administration, this region showed very thick but regular rim enhancement with non-enhancing center and surrounding reactive enhancement, suggesting an inflammatory process, and this was proved to be an abscess cavity by ultrasound and by fine needle aspiration cytology. Malignant BIRAD5 left breast mass with diffuse edematous changes of the breast. Contrast mammography reveals that this mass is actually composed of two components. A large cystic component with irregular rim enhancement, and irregular rim enhancement is a sign of malignancy, and another solid heterogeneously enhancing component situated just posterior to the nipple, pulling it inwards, with multiple rim enhancing nodules seen scattered at the periphery of this mass, denoting multicentricity. Pathology of this lesion revealed signature cell carcinoma, and this type of carcinoma is uncommon to be multicentric, but this was explained pathologically by the extensive lymphatic permeation seen in this case. Patient presented with left breast lump showing a large lobulated mass in the upper outer quadrant of the breast, categorized as BIRAD4. Contrast mammography showed that this mass was actually a multilocular cystic lesion with regular rim enhancement and multiple faintly enhancing cystic papillary projections. The multiplicity of this lesion as well as the faint enhancement suggest a benign nature, and this was proved to be multiple duct papillomas. Patient with previous right conservative surgery 5 years ago. Now the mammogram showed a questionable lesion at the lumpectomy bed. Contrast mammography can detect a small nodular enhancement at the edge of the lumpectomy bed, which suggests tumor recurrence, and this was proved to be a recurrent invasive gut carcinoma. Another recurrent lesion is a recurrent invasive lobular carcinoma at the operative bed in the form of a globular heterogeneously enhancing lesion and other tiny enhancing nodules seen scattered throughout the breast. This patient had underwent mastectomy, and the pathology revealed recurrent invasive lobular carcinoma at the operative bed and minute tumor emboli within the breast tissue. Patient with BIRAD4 right breast mass. After contrast administration, this mass showed very strong and heterogeneous enhancement, raising the BIRAD category from 4 to 5, and this was matching with the pathological diagnosis of medullary carcinoma. Patient presented with right breast lump and very dense mammogram, suspicious mass in the upper part of the right breast, not clearly seen in the craniocaudal view, but contrast mammography was superior in delineating the extensive tumor mass implicating the upper and central portion of the breast and proved to be an invasive duct carcinoma. Another invasive duct carcinoma situated just posterior to the nipple, pulling it inwards, showing moderate heterogeneous enhancement after contrast administration. Contrast mammography was superior in detecting another enhancing nodule infiltrating the inferior areolar lip, not seen in the conventional mammography. Patient with malignant right breast mass, contrast mammography was able to detect multifocal lesions in this case of invasive duct carcinoma. Patient with malignant right breast mass in the central portion of the breast with a large area of increased density close to it, harboring malignant microcalcification. Contrast mammography was amazing in detecting multicentricity in the form of multiple homogeneous and heterogeneous enhancing masses, as well as tiny enhancing nodules scattered throughout the breast. The other breast of the same patient was denser, showing retroareolar increased density, proved to be cystic regions, but there was a small enhancing nodule situated in the central portion of the breast with a distant margin, which proved by biopsy to be an invasive duct carcinoma. Bilateral mirror image invasive lobular carcinoma. Contrast mammography, the conventional mammography, suggests that there is a multifocal lesion in the right breast, but the contrast mammography excludes multifocality, as this mass, small mass which was seen in the conventional mammography, did not enhance after contrast administration and proved by pathology to be fibroadenoma. A patient who presented with multiple bone deposit, conventional mammogram suggests multifocality, but the contrast mammography was superior in precisely delineating the enhancing malignant lesion, as well as two enhancing foci not seen in the conventional mammography but only detected in the contrast mammography. The other two masses, which were considered malignant in the conventional mammogram, did not enhance after contrast administration and proved by biopsy to be fibroadenomas. The involuted calcified fibroadenoma in the left breast did not enhance after contrast administration. Left breast mass categorized as BIRAX 3, showing moderate enhancement after contrast administration with non-enhancing internal septi and proved to be a fibroadenoma. Patient with diffuse edematous changes of the breast, no mass could be detected. Contrast mammography was able to detect the tumor burden in the breast, as well as the intensely enhancing metastatic axillary lymph node, and this was proved to be invasive duct carcinoma. Patient complaining of nipple and areolar eczema with focal parenchymal distortion in the lower inner quadrant of the breast, showing ductal enhancement in the contrast mammography, and this was proved to be ductal carcinoma in situ. Patient under neoadjuvant chemotherapy with marked discrepancy in tumor size before and after contrast administration. Also multiple small cystic changes are seen within the lesion, denoting tumor response. Diffuse edematous changes of the breast with only focal distortion in the upper outer quadrant of the breast. Contrast mammography was able to detect multiple intensely enhancing nodules clustered in the upper outer quadrant of the breast, and this was proved to be invasive duct carcinoma with in situ component. Patient presented with left breast lump. Mammography was inconclusive, but contrast mammography was able to detect a heterogeneously enhancing mass in the upper outer quadrant of the breast with multiple enhancing nodules scattered at the periphery of this mass, and this was a combination of invasive duct carcinoma and invasive lobular carcinoma. Patient presented for screening mammogram. No abnormality could be detected in the mammogram except for some tinting of the posterior parenchymal edge, but after contrast mammography we can detect multiple rim-enhancing masses at the site of the parenchymal distortion, and this was proved to be a multifocal invasive lobular carcinoma. Patient presented with mass in the far medial part of the breast. Only the conventional mammogram we can detect some speculations with no definite mass. We did cleavage view for this patient, and the contrast mammography was able to detect a homogeneously enhancing large mass, well defined with long extensions extending to the medial corner of the breast, and this was proved to be a medullary carcinoma. Patient with known left breast cancer in the left axillary tail. With very dense mammogram, she is presented now with widespread metastatic deposit. Contrast mammography was amazing in detecting multiple tiny enhancing nodules throughout both breasts, representing metastatic deposit. Male patient with bronchogenic carcinoma, and now is presented with left breast lump. This mass, or this lump, showed the same pattern of enhancement as the primary tumor in the lung, and the pathology revealed metastatic deposit. Patient under neoadjuvant chemotherapy, again there is marked discrepancy in tumor size before and after contrast administration, denoting tumor response. Patient under neoadjuvant chemotherapy, the mammogram was inconclusive, but the contrast mammography we can detect a lobulated, faintly enhancing mass in the central portion of the breast, denoting residual tumor. So what are the applications of this technique? The same application as the MRI. The diagnosis of equivocal lesions on digital mammography, detection of occult lesions, especially in dense breast, precise determination of the extent of the disease, tumor size and number, assessment of operative bed local tumor recurrence, monitoring response to chemotherapy. So, now the question, can contrast mammography replace contrast MRI? I will present a few cases. This is a 44-year-old female presented for screening mammogram. The upper outer quadrant is the seat of an ill-defined mass. Both contrast examination showed the same pattern of contrast enhancement of this mass in the form of a regular rim enhancement with faintly enhancing internal cross, raising the BI-RAD category from 4 to 5, and this was matching with the pathological diagnosis of invasive duct carcinoma. Patient with a BI-RAD 3 and some we can consider it as BI-RAD for right breast mass. Both contrast examination gave the same information about this mass, about the nature of this mass, the malignant nature of this mass as proved by estrogenous enhancement and the long enhancing extension arising from this mass. Also the clumped enhancement seen located anterior to the parent mass, denoting multifocal lesion, and this was a multifocal invasive lobular carcinoma. Inconclusive mammogram, the patient was bleeding per left nipple. Both examination can detect extensive ductal enhancement, which was more obvious in the contrast mammography, but contrast MRI was superior in delineating the invasive component of this lesion, in this case of an invasive duct carcinoma with ductal carcinoma in situ. Inconclusive mammogram and both contrast examination showed multiple intensity enhancing ill-defined masses denoting multifocal cancer. The pathology was surprise, revealing the rare neuroendocrine tumor in the breast. Patient with malignant microcalcification in the breast, and both examination, the contrast mammography can detect faint ductal enhancement corresponding to the site of the microcalcification, not seen in the conventional in the MRI, but both examinations were able to detect heterogeneous regional enhancement in the lower inner quadrant of the breast, denoting invasive cancer, and this was proved to be Paget disease with invasive duct carcinoma and ductal carcinoma in situ. Malignant right breast mass, both examinations were able to detect a more extensive disease step with another mass situated just posterior to the nipple. So we can conclude that contrast enhanced spectral digital mammography could be a promising breast imaging tool. It enhances the specificity of the standard mammogram. It has a potential impact on characterization of breast lesions. It provides comparable information to MRI, superior to MRI in detecting minute enhanced tumor emboli and ductal carcinoma in situ, while contrast MRI was superior in detecting invasive duct carcinoma. Short examination time, less expensive, gives answer at the same time of mammographic examination. So it is non-inferior to breast MRI in the context of detection and characterization of breast malignancy. Moreover, it's more accessible and cost-effective. Thank you.